With that, this presentation now open to discussion and questions. And I will start with my friend Junichi Abe, who is across the street from us at MD Anderson. He would like to know, after thanking Professor Wu, he would like to know how IPS screening can be adapted to assess the long-term impact of drug on chronic diseases, such as coronary artery disease and their associated chronic side effects.
Yeah, so that's a very good question, Junichi. I think the long-term chronic studies are usually more difficult with these iPSL platform because it costs a lot of money, a lot of time to do the drug screen. You can't do that. I mean, we've cultured iPSL-derived cardiomyocytes up to 200 days, but the postdocs don't like it because there's not a lot of 200-day experiments that you can do before they graduate, before they leave the lab. But you can do that, no problem at all. So usually we would do our studies in about 40 days, 30 to 40 days. That's for the cardiomyocytes. For the endothelial cells, it's much faster. It's about 5 to 10 days study. And so studying chronic condition is more difficult because of this time and cost. But in the case of, say, for example, if you want to understand, as you put down in the chat box, atherosclerotic formation, a lot of that is mediated by, for example, macrophages. And so it's very easy for you to differentiate iPSL-derived macrophages. You can then culture your iPSL-derived macrophages from, I'm making it up, from 20, 30 people. Some of them are healthy, and some of them have genetic susceptibility, and some of them even have other genetic mutations. You can then expose them to high-fat lipids, and you can then understand what happened to the iPSL-derived macrophages individually, sequence them, and also do functional profiling to understand how different people respond. And then if you have some type of drugs that you think can mitigate this process, you can then use this as a platform to screen. But to model something that occurs over 20, 30 years, it's just not possible to do at this moment. Yeah.
Very good, Joe. So you really have successfully, I would say, debunked some of the concerns that have been out there in the society about immaturity and heterogeneity of these cells. And your application of this IPS to discovery is really, to a large degree, seems to assuage the concerns that are out there. But having said that, what's going on the other side of the coin, trying to make these cells more mature and more less heterogeneous? So, I mean, if you look at, I mean, perhaps is the centers, maybe this study should be done by
Yeah.
specialized centers such as yours, who really produces beautiful data. But if you look at data from many other centers, the data dispersion is so enormous in IPS cells that basically has a very big question about, the results that people are obtaining. So what is
Yeah.
from your perspective on that?
Yeah. So I'm gonna pull up one of the slides I show, and I think it's in my opinion, it's very important for I'm just gonna pull up this slide again. I'm gonna let me just show this this editorial right here. I think people who are in the iPSL field knows this quite well, and people who are outside of the iPSL field are not aware of this. So what you're getting at, AJ, is this right here. You want to see beautiful data, minimal differences. And if you take your HeLa cell, S9C2, C2, C12 cell lines, you do it 1,000 times, of course you're going to get beautiful data because you're just doing it on the same cell line here. On the other hand, if you do it on 1,000 different patients, you're not going to get a beautiful data like this anymore. You're going to get a lot of distributions right here. And my cell may be right here. Your cell may be right here. E-beam cell may be right here. So within the iPS cell field, we know that the variation that you see, the technical variation is much, 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 much smaller than the biological variation, meaning that in not just the cardiac field, but any other field, iPS cell, neuronal cells, iPS cell, liver cell, if you generate 3 different cell lines or 5 different cell lines and do a PC1, PC2 plot, and it's a PC1 here, PC2 here, my cells would be here, your cell would be up in the screen, and then E-beam cell will be on the corner right here. You look at it and say, well, it's all different. Well, of course it's different. We're 3 different individuals. On the other hand, if you treat my cell with drug, you'll see my drug response will shift a little bit here. Your drug response will shift a little bit here. E-beam cell drug response will shift a little bit here. So the technical variation we're getting is much, much smaller than the biological variation. And this is what I keep on trying to emphasize. Do not get fooled by this right here. You may have a drug that works beautifully well in patient number 2, and when you go to trial, it fails miserably. Well, patient number 2 doesn't represent the entire population. What you want to know is this right here. If a drug works in 1 out of 1,000 people, I'm not interested in that. If a drug works in 1,000 out of 1,000, the scientists probably made up the data. I'm looking for a drug that works in 200, 100, 150, 300 patients. And I'm trying to understand who really respond well and who don't respond well. And so this is a question about the heterogeneity that the scientists don't like to see. To us, heterogeneity is good because I want to understand who really responds and I don't want to understand who don't respond. I think the second question on your maturation is also a very good one. And we get our grants at triage all the time with the approach of 6 or 7. And the reviewer just says cells are immature and then boom, it's game over, right? The reality is that many of us are trying to push the cells to more mature. But the reality is that any cells that you grow on a tissue culture plate cannot be the same as a freshly isolated cell. Meaning that if you take a liver biopsy, immediately it looks the same as a liver. Day 1 looks slightly different. By the time you culture that liver at day 7, it's going to look completely different. And so it's unrealistic to expect a cell that cultures on a dish to be exactly the same as the freshly isolated human cardiomyocytes, or to be the same, oh yeah, these cells don't look the same as my freshly isolated mouse or rat cardiomyocyte. It's just unrealistic. On the other hand, for us, when we're trying to go after a drug or go after a disease pathway, if the particular pathway is not expressed at all in the iPS cell cardiomyocyte, then we don't even pursue it. We only pursue it if the pathway is expressed. It may be expressed at a 50% level, but it's good enough if at 50% level, when you give them some kind of stress, that stress goes up. And when you give them some kind of drug, that pathway goes down. That's good enough for us to set up an assay to start looking for the biological pathways that exist among all of us. Yeah.
Fantastic, Joe. Grateful to you. I have a number of hands up. I think Lila's hand went up first. Professor Raffaella Lombardi, better known as Lila.
Yeah. Good morning to everybody. So I work on genetic cardiomyopathies, and I also am a cardiologist, so I see this patient. And what puzzles us is the high phenotypic variability. So in the same family, you have the same causal mutation, but you see a huge clinical variability. So how is the IPS model going to help us in this regard? So how can we improve the personalized treatment of these patients? And on the same line, another problem that we have are the gene positive, phenotype negative, that sometimes they don't even develop the phenotype. So there is a way to look at these gene positive people and find a way also to maybe prevent the development of the disease.
Yeah. So I think Dr. Lombardi, those are 2 great questions. I see these patients in our clinic as well. The first one is within the same family, they have same mutation, but yet there's such a heterogeneity in terms of clinical phenotype. The heterogeneity could exist mainly because of the genetic modifiers that turn on or turn off the gene. It could also exist maybe because of differences between young versus old patients. A lot of times the patients, when they get older, they manifest the disease better. It could also be differences between men and women. For example, there's some genetic cardiomyopathy that occurs when a male hits the puberty, but less so in a female. So a lot of these you can actually model, and actually we don't have the manpower, but one of the questions that I've always wanted to do is, expose the cells from genetic cardiomyopathy patients to increasing dose of testosterone and see how that provokes it, and also increasing dose of estrogen to see how the female sex protects it. I think the second question is, what about the patients who are genotype positive and phenotype negative? I think it just begs the reality that today we still don't know that much. And I would assume when you say genotype positive, you probably send it off for Invitae, you send it off for ClinVar, you send it off for clinical genetic testing. For those patients, I would advocate to do whole genome sequencing, especially if it runs in a large family. And it may not exist in the genes. It may exist somewhere on the epigenetic level, and it may exist somewhere on the non-coding RNA level that a lot of people are finding out. But this is an area that the iPSC, in my opinion, is perfect for you to study this, because you're generating the cells, you're differentiating them. It gives you time to kind of work out the mechanism of how this particular family has this particular disease phenotype. And if you do have these large family patients, we're happy to help you. We get referrals from a lot of clinicians throughout the country that sends us a large family cohorts at the study. Yeah.
So, Joe, I think Dr. Hu was next raising her hand, and then we will follow with our friend Yibin. Dr. Hu.
Hi, Joe. This is really wonderful talk. I have two questions. One is to evaluate or predict the drug safety and efficacy. The iPS-derived cell or organized can be used. So, which one you suggest for the drug safety and efficacy predictor? We can use cells or organoid.
Yeah, so that's a good question, the cells and the organoids. I think I have a slide on that because we get asked all the time. The answer is there's no easy answer, meaning that it depends on where you at the initial drug development process. I'll just give you an example of a project that when the process of finishing up. In that project, we're looking for anti-fibrosis, and our primary screen is created using a iPS cell line that has ACTA2 driving GFP. And so when you give her the TGF-beta, the GFP shoots up. And then we will screen for about 50,000 compounds to see what causes the GFP to come down. That's a primary screen using one cell line. That's genetically modified. And once you get hits, then you want to do a 7-dose titration to further refine the number of hits. Once you get that hits, you can take those hits and put it on 20 different patients to make sure that you could have a hit that work on patient number 1 beautifully, beautiful data, but it doesn't work on patient number 2, 3, 4, 5, 6, and all the way up to 20. Then that I'm not interested in. I'm looking for a hit that works in reasonably half of my patients. So we would then take that hit, expand it to about 20 different cell lines. In this case, still using 2D. Once we further narrow it down, we would take those narrowed down lists, put it on the 3D, because for the 3D, it's going to take you more time and more money, and also more variability, because depending on how you generate the 3D, some of the 3D is just based on spontaneous differentiation of the 3D. You don't have a good control of over what percent cardiomyocyte, what percent fibroblast, what percent endothelial cell, what percent smooth muscle. Some of the 3D we do is we just spike in the exact number and let them form. But then if you spike in the exact number and let them form, this cells are spiking means somebody needs to differentiate batch of cardiomyocyte, another batch endothelial cell, another batch of smooth muscle. So the answer is that there's no such thing as this thing is better than the other. It just depends on what stage of your drug development process you then choose what model you want. Yeah.
Okay, thanks.
Thank
So
you.
the third,
We have one more question by Professor Yibing Wang. There's a couple of questions online. I think you covered them during conversation. So Yibing, please.
I know it's late, so I want to congratulate Joe. You have pioneered the field and really opened up so many opportunities for the increase. And I have two questions actually try to, I guess, challenge the iPS-derived cardiomyocytes as a field. One is really what you already alluded is the cell-cell interaction complexity, where most of the cell system that you actually alluded are still relatively simple compared to the impact heart. The second is really the disease that actually that we are all facing in majority of our patients, let's say, whether it's a mechanical overloaded or it's a metabolic associated HAPAP. Do you think there is a genetic component in those disease onset, and that you can use iPSL-derived cardiomyocytes to actually simulate those disease properly as a model organism?
Yeah, so two great questions. I think the first question is looking at the cell-cell interaction. I didn't show too much of it because we still have a lot of projects on that. I actually think this is a perfect model to study cell-cell interaction in a human platform. And the main reason is that now we can differentiate separately iPSL-derived cardiomyocytes, endothelial cells, and we have protocols of all of them that we can share. iPSL-derived cardiomyocytes, endothelial cells, smooth muscle cells, pericytes, fibroblasts, and macrophages, right? The big 5+1 cell type. You can put them all together, and before, let's say 10 years ago, you can't sort out what's going on. But 10 years later, because of the single cell sequencing, it's very easy for us to sort out. You put it all together at baseline, and then you expose them to different stress conditions, or different mechanical loading, and you sequence it again so that you understand what is the effect of the stress on the iPSL cardiomyocytes, endothelial cells, fibroblasts, smooth muscle cells, pericytes, and macrophages. This is actually a great model now because you can deconvolute what's going on. With regard to the second question, the HFpEF question, heart failure with preserved EF, if I understand it correctly, the question is whether this is genetic and whether you can model this. My own take is that most of the diseases, all of us have genetic involved. There's always genetic component to it, but its question is how much. And my take on that is HFpEF, especially in the US, it's essentially a disease of the aging, disease of obesity, right? If you look at, for example, the trials by Novo Nordisk on semaglutide, the SELECT trial that the FDA approved for patients with HFpEF, patients with not HFpEF, but patients with obesity, non-diabetic, prior history of heart attack, peripheral artery disease, and stroke. And they get semaglutide, and they showed it helps them. All the patients that they enrolled were average BMI of 30. Right, average BMI of 30, and they lost about 10% weight. And if you lose 10% weight, you feel better. You don't complain to your doctors that much, and the doctor doesn't send you to the hospital. If you don't get sent to the hospital, there's less chance that people are going to check your troponin, because every time when you show up in the hospital, troponin is always positive, and there's less chance people coding you as a myocardial infarction, right? And so a lot of that, in my opinion, for the HFpEF, and for people who are doing HFpEF, you have to think about, well, these incretins is gonna have a big play in terms of HFpEF. What else is left? Well, what else is left is really the HFpEF patient, what I would call the Japanese HFpEF versus the American HFpEF. American HFpEF, like us, is really big, a big BMI. The Japanese HFpEF is probably just elderly, aging, and are there additional drugs that you could develop to model that? And so for those of you who's interested in that, what you could probably do is for the American HFpEF, you could just look at the American cohorts and look at the biomarkers and see what is the difference between our population who are HFpEF versus non-HFpEF, meaning hypothetically interleukin-2 is elevated, and this particular cytokine is elevated, that cytokine is elevated. Then you could come up with your own cocktail, a HFpEF cocktail that you could expose to your cells. I guarantee you, if you look at the same thing in the Japanese population, those biomarkers will probably look different because in the Japanese population, they just have less BMI of 30, right? And so their biomarkers may be more of an aging-related, hypertension-related, and so forth. And again, you could create a different HFpEF cocktail for that. But it would be nice to be able to come up with a drug that has nothing to do with weight loss and show that the drug works. But currently, right now, the drug that really works well are the ones that cause our patients to lose weight. Yeah.